Starting with the first part on basic anatomy and embryology, we'll be discussing some congenital and developmental lesions as well. The Sellar and parasellar region is a fairly complex region of anatomy, and that is partially related to the complexity of the architecture of the sphenoid bone. The sphenoid bone has the shape of a butterfly or a bat with open wings. It has a central body that has the shape of a cube that is marginated laterally by grooves for the internal carotid arteries. Anteriorly and laterally, it extends through the small wings or lesser wings, and the relatively flat surface between those two is the planum sphenoidale. Between the planum sphenoidale and the anterior clinoid processes, we have the optic canals bilaterally, the chiasmatic sulcus, where the optic chiasm lies. Between the tuberculum sella and the dorsum sella, we have the cavity for the pituitary gland, which is bounded laterally by the cavernous sinuses. Along the anterior and lateral surface, we have the greater wings of the sphenoid, and between the greater wings and the lesser wings, we have the superior orbital fissures, which carry many structures, among which we find the first division of the trigeminal nerve. The second division courses anteriorly through foramen rotundum, third division through foramen ovale, and posteriorly we have the foramen spinosum with the middle meningeal artery. On coronal illustrations, we can see the distribution of the cranial nerves within the cavernous sinuses. We have cranial nerve 3, 4, the first and the second divisions of cranial nerve 5. Remember that the third division already came out through foramen ovale. We have the sixth cranial nerve, which is the most medially located cranial nerve within the cavernous sinuses, and therefore the one that is most commonly affected by aneurysms from the ICA as well as lesions in the skull base. This is a sagittal, this is a coronal image, CISS. I'm sorry, I'm gonna start this slide again. So this is a coronal illustration where we can see the distribution of the cranial nerves as they course through the cavernous sinuses. We have the third cranial nerve, fourth cranial nerve, the first and second divisions of the trigeminal nerve. Remember that the third division of the trigeminal nerve already came out through the foramen ovale, and the most medially located cranial nerve is cranial nerve 6, which is the one that is most commonly affected by aneurysms and by other lesions in the central skull base. We have a coronal CISS image, also known as Fiesta for other vendors, where we can see the third cranial nerve, first and second divisions of the trigeminal nerve, and we can see the sixth cranial nerve. This is an image that has been acquired after contrast, so we do see some enhancement of the cavernous sinus. The fourth cranial nerve we're not going to see because it is very thin, unless we do thin images going down to 0.4 millimeters in thickness. On this sagittal illustration, we see the pituitary gland, we see the thin infundibulum, the optic chiasm above it, we see two sharp recesses, the suprachiasmatic recess and the infundibular recess. On this sagittal cis reconstruction, we can see those sharply defined recesses, the suprachiasmatic recess and the infundibular recess. Again, these should be open and free of any tissues or any lesions. Sometimes we may see it on the conventional sagittal spin echo T1 weighted images, but that may be a little bit more difficult. In this sagittal T1 image without contrast, we can see the suprachiasmatic recess. We see a little bit of the infundibular recess. More posteriorly, we see the posterior pituitary bright spot, which we should be able to identify in almost all patients. Basic embryological concepts are going to be helpful to try to understand how and why some of these lesions and where they may develop. At around week 3 of embryonal life, we see here marked in orange the primitive oral cavity. We start seeing a diverticulum that courses or starts forming cranially, and separate from that, we see a small infundibulum arising from the diencephalum that courses anteriorly. These two come together, but before they do come together, the diverticulum starts forming a pouch. When the pouch contacts the infundibulum, it loses its connection with the primitive oral cavity. And what happens finally is that the anterior wall of that pouch, of that bag, starts filling with cells. And at the end, we get the greater mass of the adenohypophysis, which is the pars distalis anteriorly, the pars intermedia posteriorly, which degenerates. Between those two, we have a cleft, which is Rathke's cleft, and we have the pars tuberalis, which grows cranially around the infundibulum. So let's look at this case. Anteriorly, we have displaced pars distalis of the pituitary gland. Posteriorly, we have the pars intermedia that looks thinned. In between those two, we have a lesion that is bright on T1. This is a non-contrast study, and this is, of course, a Rathke's cleft cyst. And posterior to that, we see the posterior pituitary bright spot, which is separate from the lesion. So Rathke's cleft cysts are benign lesions. They are almost always asymptomatic, but they may grow and they rarely can cause symptoms. Most of them have suprasellar extension. The signal intensity of the lesion is going to vary depending on the contents of the cyst. If there's high contents of mucin or protein, they will be bright on T1. They can be bright on T2 weighted images. About a third of them are hypointense or isointense on T2 weighted images, and it is relatively characteristic finding. They should not have enhancement and they do not calcify. This is a different patient where we can see a cystic lesion along the superior aspect of the pituitary gland, and we see the compressed pituitary gland inferiorly. On the pre-contrast T1, we see that there is a round nodule that is bright. There is no additional enhancement on post-contrast images. And on the axial T2 weighted images, we see that the nodule is very dark on the right side. Coronal T2 images of the same patient show the nodule within the lesion on the right side that is very dark on T2, very bright on T1, and there is no superimposed contrast enhancement. This is a highly characteristic imaging feature of Rathke's cleft cyst, if not pathognomonic. So when we see it, what this represents is a small mass of mucin and cholesterol, and it is almost pathognomonic, as I mentioned, of Rathke's cleft cysts. Now let's look at a different patient. We have sagittal T1 weighted images with contrast, and we see a cystic lesion in the region of the infundibulum and hypothalamus. It looks fairly cystic on the T2 weighted images, but we see on the FLAIR images that it does not suppress, and it has some signal within it and the so-called dirty appearance, and this is, of course, the case of an epidermoid tumor. And the most important sequence now that we can get diffusion is the DWI images, and we can see that the lesion is very, very bright on diffusion, almost bright as a light bulb, but on the ADC maps, it's not as dark as we would have expected for the degree of restricted diffusion. Therefore, people think that there may be some T2 shine-through effects that account for part of this brightness. So this is an epidermoid tumor. Epidermoid tumors are retained epithelial elements, and basically they constitute masses of keratin, as opposed to dermoids. Epidermoids do not have skin appendages. They are much more common than dermoids, and half of them occur in the cerebellopontine angle, but a good proportion of them occur in the suprasellar region. Very rarely, epidermoids as well as dermoids can degenerate into squamous cell carcinomas because they are epithelial cells. So the two most important features are brightness on diffusion weighted images and lack of suppression with a so-called dirty signal or dirty appearance on FLAIR images. Moving on to a different case, different patient, sagittal T1 weighted image without contrast in a child. We see this large cystic lesion in the suprasellar region extending to compress the hypothalamus superiorly. Posteriorly, there's compression of the brainstem. On the axial T2 weighted images, we can see that the lesion looks fairly cystic. There is splaying of the midbrain as well as of the vessels of the circle of Willis. And we see that on the FLAIR images, it fully suppresses, and therefore this is not an epidermoid tumor, but this is an arachnoid cyst. So almost always arachnoid cysts are going to be asymptomatic, but some of them can continue to grow. They may or may not communicate with the subarachnoid space, and very, very rarely they can also hemorrhage. But for the most part, they are asymptomatic. And if they occur in this region, symptoms will be, if present, associated with compression of the hypothalamus or the pituitary or infundibulum. This is a different patient. We have a sagittal T1 weighted image in a child where we see this lesion in the region of the hypothalamus and infundibulum that is relatively isointense to the cortex. We see on the coronal T1 weighted reconstructions the mass along the inferior aspect of the third ventricle. We can see how the fornices are splayed to the sides, and we can see a small portion of the third ventricle along the superior aspect of the lesion. Again, we see that the lesion looks very much the signal intensity of the cortex. On the T2-weighted image, the lesion is a little bit brighter than cortex. And on the sagittal post-contrast images, we see that there's no enhancement. So this will be a great location for a hamartoma, a tuberosynerium hamartoma occurring along the floor of the hypothalamus. We know that these lesions are very rare. We mostly see them in children. They can present with precocious puberty. They can have seizures. There is this characteristic clinical syndrome of gelastic seizures that people present with laughing spells, which has been described with hamartomas. For the most part, they do follow gray matter signal, but they can have hyperintensity on FLAIR or T2-weighted images depending on their content of gliosis. They should not enhance, but some of them can have calcifications. Thank you. With this, we conclude the first part of the talk.